And then it allows you to sort of work backwards and drop little breadcrumbs, if you will, back to the main airway so you can figure out what airway you're actually going to take. So here's that process here. What we're doing is rotating this around and looking for a bronchus. So here's a bronchus close to the lesion. And then you can see here, that starts to connect to this bigger bronchus, so we're going to start dropping breadcrumbs back here. So you drop another one there, drop another one there, and then that connects ultimately to the trachea, and so now you've delineated the pathway that you're going to use. A 3D bronchogram is generated, so you can look at the pathway both from inside the bronchus as well as from outside the bronchus. And this bronchial tree, as I'll show you later, can be flipped any way you want. You know, you can flip it on its head, you can flip it inside out, you know, to give you whatever view you think is the best view for seeing where you're going to make your turns. So the other thing I think that's very important to notice, you saw how this screen here just flipped from an inside view to a more virtual view. And that's because we switched from a part of the bronchus that we can actually see through the bronchoscope to one we're not going to be able to see, and where we're going to have to put a special steerable catheter out guided by this GPS system, which is essentially why I'm calling it a GPS for the lung. So as long as that pathway stays purple, that's sort of like a purple brick road, if you will, you just follow that out to the lesion. So once we get to the OR to do the procedure, you know, that's all planning that's done ahead of time. In the operating room, this is what it looks like. So, you know, it's generally, I put the patient on a general anesthetic with an endotracheal tube in place. Although there are people who are starting to experiment with doing this under heavy sedation with no endotracheal tube. The operator stands at the head, the bronchoscope is advanced into the lung. This is the setup that you're going to see with multiple different screens, so you can look at either the pathway or the map or whatever you want. First part is to do what's called a registration. So we want to basically combine the CT images with the patient's anatomy. We put these special markers on the patient's chest, which literally is a GPS system. It's an electromagnetic field that surrounds the patient's chest and hybridizes that information to the information on the CT scan. And that generates the pathway. And then you start getting these views as the operator. You can see both in the axial, sagittal, coronal planes. You can see the internal, you can see all these. You can set whatever views are most helpful to you at the time to start using the bronchoscope to steer out to the lesion. And as you're steering, you have a character that shows you where the tip of your sensor is, and that sensor follows the path, and this is generally what the target is represented at, and it gives you how far away from the target you are as you're coming closer and closer to it. So it's, like I said at the beginning, it's sort of like a targeting system for a missile, and you can see how this was adapted from military technology. That allows you to do a bunch of different things in terms of biopsying, and we'll get into that in a second, but let me show you. Let's see, we want this to work. All right, so this is another movie now that's going to kind of show the procedure as it's being done. So what you see on the screen when you start, this is an internal view from the bronchoscope. And this is the sensor coming out the edge of the bronchoscope. So the first thing you do is you just go and you touch all the different subsegments of the bronchial tree. And then when this turns green, your virtual bronchogram will come up over here. So this is the registration between the GPS system and the CT information. You'll see in a second this will turn green, and then the virtual bronchogram will pop up. And this is actually what occurs. So now now this is green, so all that has been hybridized, and we have a virtual bronchogram. Now, what you can do with the virtual bronchogram, it's sort of like with an iPad. You know, sometimes it's a little bit skewed, so you can actually turn it around and make it look exactly, that's what they're doing right there. Sort of make it adjust to what you're seeing through your scope. Then you take your pathway, and for this lesion, you're going to just follow that pathway, and you get to a point where you can no longer see through the end of the scope. So now you're taking your working catheter, which is going through the working channel of the scope, and just slowly making the turns along the pathway that's been generated, along the virtual bronchogram. You hit various waypoints, and then ultimately you get out to the lesion. And generally once you get good at it, it takes about 5 or 6 minutes to get out to the lesion. It's really not too hard.
But you really can't see.
No, you can't see at all. This is all virtual. It really is. I mean, when people watch this in the operating room, you really get the feeling like it's a video game, because you're not really seeing what you're doing. You're sort of sensing what you're doing, much like, and I use that analogy again, much like a fighter pilot would in an F-14. If you're going to shoot at something, you don't really see it hit the target. You're miles and miles away, and it's very similar to this, but this is obviously a nice peaceful use of that sort of technology. So this is looking at what the scope and what the working channel look like under fluoroscopy. You can do a whole bunch of different things, either putting, here you're putting a fiducial, which means just a marker that can be left to be seen radiographically to guide radiation therapy. You can put a forceps out and get biopsies. And you can also do things in the central airways with a lot more precision than you could ordinarily. So in a lot of ways, this is also replacing endobronchial ultrasounds. So the nice thing in the operating room is you have all these different views that you can look at. One of the views is this local view. So you can see, well, here's the pathway, and this is sort of a generated image. You can see, let's see if this advances, a static 3D map of the bronchial tree and where you're going, with the sensor located exactly where you want it to be. The dynamic map is the one that you can kind of flip around if you want to look from behind at where the junction is, because that gives you a better view of how it's splayed out. So, I mean, it's a very, very powerful technology. And as I said, there are a number of things that you can do with it. One is certainly you can use biopsy forceps to get out. Sometimes, as with any other technique, you're limited by the amount of tissue that you're going to get. You can't get huge hunks of tissue. But most of the times, you can get a good amount of tissue to at least make a diagnosis. You can put fiducial markers. As I said, it's basically pushing a little pellet through the working channel, so it plops out by where the lesion is, and that can guide the radiation oncologist if it turns out that the lesion has to be radiated. The other thing that I particularly think is kind of cool is you can do this tattooing. So you can, for a peripheral lesion, kind of inject a little bit of dye right where the lesion is, and as I said, when you're doing something minimally invasively, you lose that tactile feedback, and this gives you a visual cue as to where to cut. So I wanted to give you a quick case presentation. If you were here last week, you heard it, but I'll show it again, of how this kind of all comes together with a patient. 72-year-old woman with a fairly obese habitus and very bad pulmonary reserve from long smoking history, was noted to have, not on a screening CT, this was beforehand, but we know that we all come across incidental type of nodules on CT scans. She had a 6 millimeter nodule noted about 6 or 8 months ago. And on repeat, it had grown to 9 millimeters. So the first thing I did was I took her to the OR and I biopsied her with the navigational scope. And we were lucky enough to have pathology present in the OR, and they told us they saw atypical cells, which frankly in this kind of clinical context can only mean one thing. So we scheduled her for a resection because that's pretty strong evidence that it's going to ultimately be a cancer. And we resected her with a robotic approach where we tattooed it intraoperatively. And so hopefully this works too. So let's see. Can you all see this okay up there? Okay. So this instrument is probably about 2 centimeters long and has an opening of about 1 centimeter to give you a scale for what the size is. And here you can see from the side, you see that blue dye, sort of like a blue brick road, that's leading out to what we're going to see here is this nodule, right? So obviously that would have been suspicious by vision, but we have no way of knowing ahead of time whether we're going to be lucky enough to see an indentation of the pleura. Sometimes we don't see it. And in that case, where this dye was would pretty much be our target for what we're going to resect. And you can see right here how it's starting to look ugly, right? And so we ultimately took that out. We did a wedge on her because of her pulmonary reserve. And the final pathology showed it to be a 7 millimeter adenocarcinoma with margin negative. Thankfully her nodes were negative. Poorly differentiated, so somewhat aggressive tumor. But hopefully this is the type of thing that we can look forward to more and more in the future. As I said, if you kind of think about breast cancer back in the 70s and where we are with breast cancer now, my dad is a general surgeon. I remember him talking about doing, things like the urban procedure where they took out part of the chest wall and they did these radical resections of muscle to get margins on tumors that were relatively big. And now, because we have breast ultrasound and breast MRI, we detect lesions that are, almost on the verge of, just becoming a cancer, and they're so small, and we can wedge them out and we treat them in a much more minimally invasive way, and in a way that's much better for the patient, with much better survivals. And so the hope is that by synergizing screening for cancers and getting cancers at an earlier and earlier stage, and having technologies like this and technologies like robotic assistance, that 5, 10, 15, 20 years from now, we get to a point where lung cancer has a much better survival than it does now, and maybe starts to approach the types of survivals we routinely see in breast cancer. Right now, a 15% 5-year survival for a disease process that affects 400,000 people every year is a tremendous scourge on the society, both in terms of lost productivity and tragedy in personal lives and economic costs. So the more that we can kind of bend that curve, I think the better it's going to be in all those different areas. So once again, just to review the types of capabilities this technology has, it's not only to be able to navigate to lesions and to biopsy them, but to also biopsy lymph nodes, and also to place markers to guide treatment and to localize lesions for intraoperative resection. And want to show once again these two recommendations from the American College of Chest Physicians, because in many ways, I think every time we in medicine are introduced to a new technology or introduced to a new modality, there's always a healthy skepticism that we have as whether or not we should really adopt this fully. And I think now we're sort of moving to a point where big organizations are really trying to, direct us and say, this is a consensus statement from the American College of Chest Physicians that, with respect to CT-guided biopsies, that's a very good technology for certain lesions, but for many other lesions, we probably should start to consider navigational bronchoscopy, mostly because the complication profile is so much lower. I mean, it's literally an order of magnitude lower. If CT-guided biopsies have a 5 or 10 or even 15% pneumothorax rate, the pneumothorax rate for navigational bronchoscopy is less than 1%. If there's a 1, 5, or 10% rate of bleeding, however you want to judge it based on the severity of bleeding, the chance of bleeding with navigational bronchoscopy is literally an order of magnitude less. And so if we can even approach the types of diagnostic yields, I think we all kind of go by the Hippocratic Oath, first of all, do no harm, and we try to do the more minimally invasive thing first and build up to the more invasive things. And I think that's probably the best reason why navigational bronchoscopy should start taking its place as the more common way to approach these nodules. We won't get the answer all the time, but certainly we do it at a much less risk to the patient. So, all of these types of patients ultimately may benefit from this. I mean, I think much like we saw in vascular surgery, the dogma when I was training was that people should only be intervened upon when they had rest pain. And that's because the risk-benefit profile was so high for an open procedure. But as we became more facile and more able to deliver things endovascularly and the risk came down, we can see that actually we can start to offer it to more people, and maybe the threshold for intervening starts to come down. This is starting to be more broadly applied throughout the country. You can see, as in most things, the Northeast are early adopters. This is where I introduced it up in Maine before I came here. And it's still fairly poorly penetrating in the West, but that's going to change. Talked about synergism. I want to just throw that in one more time to kind of make the appeal that, you know, these are the types of things we really want to look for in medicine, where things synergize, not just additive, but actually make each other better. You know, that's the type of teammate you want when you're playing basketball. Is the guy who's going to make you look good, and this is the type of thing in medicine too. Is, you know, the type of procedure that's going to make other procedures more effective. And you know, this is just a quick slide to throw in at the end, you know, about the promise we all have in terms of being able to do more cases and help patients. All right, well, thank you very much for that.